Thank you, and I believe that I will speak English. First of all, I should like to thank the organizers for this invitation. It's always a pleasure to be in Paris, and especially to be in a session on strokes, which is something new for us, our SRLF. I want to discuss malignant strokes and start with a clinical case. We had the man, 48 years of age, no precedents, no history, who had a headache, who had complaints of nausea, vomiting, decides to go to bed, slept until 7 p.m. When he woke up, there was a revulsion of the eyes and a right-hand hemi syndrome, phasal disorders, called for help, for emergency services. They arrived at 9:15. The Glasgow score was 9, difficult to assess because of the expressive aphasia, jet vomiting, and therefore the patient was intubated and taken to the shock room at 10 p.m. And a CT scan was conducted on his brain at 10:30. This is a picture of the angio CT scan. You can see an ischemic stroke on the left-hand side, and you see an occlusion in the deep end surface areas related to a gradual occlusion of the internal left carotid artery, and also a proximal occlusion of the M1 segment on the middle cerebral artery, and there was no bleeding, no hemorrhage or hemorrhagic development. So that's the sort of thing we come across in our center. Something about perfusion in the care of such patients. You can see on the left-hand side, most of the stroke affected the left-hand side of the brain. You have a contrasting agent, and you measure the volume. That is, you work out the cerebral blood flow on the left-hand side, and all these areas are ischemic areas. This ischemia, well, you have a collapse of the cerebral blood and an increase in the time of transit. So this patient, 6 hours after the first symptoms, has an established ischemia, and in intensive care we found that there's no thrombolysis, and so he was sent to our department, to our unit. Now, it is not for me to discuss intravenous or arterial thrombosis, but I would like to discuss the management of such patients. So this is at R12. You have a hypodensity there, which covers just about all of the left hemisphere, and you have an effacement of the left ventricular line. Diana's line is collapsed as well. So this is a high-risk malignant AVC with the cerebral edema. So the radiologist said there's no shift. Well, there's a bit of shift on the median line. And so we had a CT scan of the brain, and on the same day we find a subocclusion of the M1 segment. We stop sedation, and the first clinical examination shows that the patient was present, as it were. There's no deterioration of the initial vasal depression, and the motor expression remains stable. So from then, what do? You have the primary lesion. that's what happens in ischemic stroke, and then the secondary lesion. And so what do? You refer to the cerebral edema and intracranial hypertension. You have a secondary cerebral ischemia and disorders in cerebral autoregulation. That is that area that could be saved in the patient's brain. And then you have a secondary cerebral aggressions of systemic origin, what is known in French as axos, and we will look more specifically at hyperglycemia and temperature. So, first, cerebral edema. The first monitoring is, of course, clinical monitoring, and the first thing is cerebral CT scan. And so clinical monitoring includes the Glasgow score, but also the motor response, because you have to monitor these patients hour on hour and conduct a Glasgow score and look at the motor response. Pupils, and if there's a deterioration, you have to have a native a CT scan to see whether there's any change in cerebral edema. What are the risk factors associated with a mass effect and cerebral edema? Well, malignant stroke means that the stroke has on top of that cerebral edema and involvement of the brain. The initial score, known as NIHSS, this is something that measures the motor response and the verbal response upon awakening. You can see that the patient had a pretty high score, but he had jet vomiting. And there are radiological factors. We had an X-ray. We found that in the hypodensity, more than half of the area is covered, and there's several areas that are involved, and the left carotid artery is displaced. Now, you also have to look at cerebellum ischemia, infarctions, I beg your pardon. The disorders are disorders in vigilance, and so you have radiologically what you will find on the CT scan is significant hypodensity, displacement of the fourth ventricle, and there is a dilation of the temporal horns, what is known as obstructive hydrocephaly. And so it's and displacement of the brainstem, and so it's pretty sure that in this case you have to have decompressive surgery because you have compression of the basal cisterns. Now there are non-cerebral. I mean, cerebral you have a seizure or hemorrhage development, but systemic you have infections, hyperglycemia, but also sodium disorders, disturbances, and also disruptions of the pulmonary function. So how do you address this? How do you manage cerebral edema? Well, when you have the first clinical signs of cerebral involvement and a drop in the Glasgow score and anisoscoria, this is an emergency situation. It has to be addressed aggressively with osmosis. Mannitol takes brain out of the brain. You could also use NaCl solution. If that was not done, you have to intubate and mechanically ventilate the patient. You have to supply enough oxygen, have moderate transitional hyperventilation, which should bring about a vasoconstrictor effect and so reduce the blood flow. And then you have emergency neurosurgery, and that is decompressive craniectomy. There was a survey conducted by the Cambridge team looking at decompressive craniectomy in cases of trauma. So you have the brain, the skull compressing the brain, and you want to let it expand. Again, this is a vital intervention, so you have to have a hemicraniectomy, a pretty wide thing. Then you have glioplasty. The reason you do this is that you want to bring down intracranial pressure. This is very effective. it is a very effective procedure if you want to bring down intracranial pressure. Having said that, should you do it for every patient? Well, this survey covers the 4 major studies that were conducted and that were randomized, controlled studies which tested out the effects of surgical decompression in a case of malignant ischemic stroke. And what was found is you have the 3 major surveys looking at age. Well, when I say major surveys, we're not talking at huge numbers, but still the most significant surveys in terms of evidence. And so the age is anywhere between 18 and 55, 60, or indeed 65. Here you have a survey going all the way up to 80 years of age. If you look at the 3 major surveys, you have something that occurs very early on, below 6 hours, or between 6 and 12, 12 and 36 hours. But that is the key message. You have to go quickly. In other words, decompressive surgery in this context must be conducted rapidly. The outcomes, well, you have favorable outcomes. You have a beneficial effect on survival. The big question is, well, then what do you do with the patient? It's all very well for the patient to survive, but how will patients survive? Well, we haven't got a clear-cut answer to that. We need more hindsight, and of course, there's a major ethical discussion as to whether you want to keep these patients alive. But the age limit is now looked at 55 to 60. But a second test has brought the age up to 60. In our own center, it's 50 to 55. You have to see whether it is if the patient is brain dead or not. The 2 main criteria are, of course, the age of the patient and of course, whether it is a dominating area or not in the brain. And so the question is, is the patient age more than 50 or 55, with a major stroke in the left-hand part of the brain? But of course, this is a very complicated debate if you look at the medical and economic consequences on the decision, because of course, neurologically, these patients have a very uncertain outcome. Now, should you monitor intracranial pressure? Well, based on this study, no. This is a rather small, limited survey, but there's one clear point. More than half of that group had intracranial pressure measured as normal, and yet there were cases of involvement. The median displacements were more than 5 millimeters, and there was a cystine effacement and 2 patients with anisoscoria, even though intracranial pressure was good. If craniectomy is considered, then you should avoid antiplatelet agents, or if there were antiplatelet, then you have to have a platelet transfusion. Now, cerebral ischemia, it's not for me to go into all the details of that, but you want to see how blood pressure adapts to these situations where you have acute cerebral lesions. Now, this is a standard, a normal situation. In other words, when the systemic blood pressure comes down, the brain adapts, and there is vasodilation. That means that the cerebral blood flow remains constant, or rather cerebral blood volume remains constant, and so blood flow remains the same. And that is, this is the standard, the control situation where cerebral blood flow remains constant. Now you have a situation where, well, we sort of amplify the situation where autoregulation is impaired. In these systemic situations, cerebral blood flow goes hand in hand with blood pressure, with intracranial pressure, rather. And so you can see that in that case there is a risk of cerebral hypoperfusion or insufficient systemic arterial pressure. So these criteria are very much used, and these pictures illustrate the concept of ischemic penumbra. Here you have a CT scan that shows an ischemia. If you do a perfusion CT scan, in other words, you inject a contrast agent and you work out the average transit time, or rather the median transit time. In blue, you can see that cerebral blood flow is low. That's the area where this is the core of the ischemia. This is irreversible. No point trying to bring up the blood pressure. That part of the brain is lost for good. However, if you look at cerebral blood flow between here on the right-hand side and the left-hand side, you can see that there's a lesser cerebral blood flow compared to the left. I mean, so there's more blue, less red. And so what happens, there's self-regulation, what is known as autoregulation of the brain. The homolateral volume of ischemia is increased compared to the contralateral. There's more red. That's the vasodilation I was referring to. And the medium transit time is extended. And so this is what is known as ischemic penumbra. This is a zone of potentially reversible ischemia where the cerebral blood flow has come down but has not gone for good. And that is the area you want to save, because in this case, the patient, if they lose the entire right-hand side of the brain, well, they've had it, haven't they? So what you do? Well, you bring up the arterial blood pressure. Now, you may remember with meningitis hemorrhage, you tend to have increased arterial blood pressure. The high blood pressure is in fact a protection here. And this survey was conducted by a German team. You found that patients were monitored with the MPAP was monitored, and there was a transcranial Doppler measuring the ipsilateral speeds on the side of the scrot and contralateral on the other side. And so you had induced high pressure, hypertension, but you don't want to bring down that pressure. In other words, you have to tolerate high blood pressure. You want to avoid vasopressors that would bring pressure down. You have to maintain adequate levels of volemia with vascular filling, with salt solutions. You could even give lactate. That's okay for the brain. Avoid colloids or albumin. There was a recent survey that looked at the effects of albumin. There were more complications amongst stroke patients, and you have to tolerate blood pressure. Means you don't bring it down unless you have hemorrhage transformation of strokes, and address it only if you have extreme hypertension or if you have associated heart failures or heart disease. So now let's take a look at these secondary cerebral aggressions of systemic origins, what we call in French axos. Here, this is an experimental research conducted in rodents. You had central hyperthermia. You have a rat then. Infarction is induced. You have thrombolysis, and you work out the percentage of the infarcted areas. You do this at 37 degrees. 38 degrees, you start losing, and at 39 degrees, RTPA doesn't work at all. So hyperthermia, high temperature, brings about a deleterious effect, a harmful effect in reperfusion. I do like this clinical experiment. Now, this is a clinical here on human beings, where you find that the Scottish group, I believe, measured with MRI, measured the temperature in various parts of the brain in the ischemic body on the left-hand side and contralaterally. Now, you find find that where there is ischemia, temperature is higher, the brain heats up, but there's a correlation between temperature and outcome, a close correlation independent of counterlateral temperature. In other words, patients with a temperature, a higher temperature distal from the infarction had a higher risk of seeing that infarction expand and a development towards an unfavorable outcome. So this work shows just how important it is to look at temperature. A number of surveys have shown a correlation between hyperthermia and poor outcome. And so we tried to look at the new practices of care. This is in reanimation for stroke patients. It depends, of course, on how severely affected the patient are. If the patient is awake, there's no need to put him to sleep or sedate him. But when you have a malignant stroke, this is a high-risk patient. By the way, a word about hyperglycemia. Let me just say that hyperglycemia in the experimental model, more than 15 millimoles per liter, 220 milligrams per deciliter, deteriorates the lesion, increases the area where perfusion is impaired. At the same time, the brain needs glucose. That glucose is provided systemically, and so you have to find the right balance. And so several have shown that forced insulin therapy is harmful for the cerebral edema. When you measure cellular circulation, and there are 3 surveys that were conducted in ischemic strokes, where we found there was, if you compare moderate versus moderate insulin therapy plus hypoglycemia when you have intensive insulin therapy, then we have a French study conducted at Pitié-Salpêtrière, 180 patients. They had intensive insulin therapy versus conventional insulin subcutaneously with a target of 7. We have the 2 group, 90 patients in each group, and you had glycemia in the standard group and the glycemia in the intensive group, and the result is that you find that there are more progressions of infarction in the intensive insulin patients, especially in those patients who had a problem with canalization.